Our topic for today, as Dr. Messmore mentioned, is the pharmacotherapy of tobacco use disorder. Our objectives for this brief didactic are to identify the pharmacologic targets of the treatments we can use for tobacco use disorder, those that are approved, list the adverse effects, as well as compare some efficacy data. I did throw in a little bit of information at the very end about another potential intervention that has been recommended for tobacco use disorder, but we'll just talk about that briefly right at the end. Most of the rest of these are on label. So in thinking about this particular topic, I thought it would be helpful to start at the beginning versus diving right into to the treatments that we have. So tobacco has been used, it's estimated since about, for over 8,000 years. They've found evidence of cultivated tobacco in different caves throughout the world that are over 1,000 or 2,000 years old. In the past, it was thought that the tobacco had been used for both religious and medicinal purposes. And in some cases, the medicinal purposes were relatively ubiquitous, that they would use them for a whole range of different things. It's fascinating that as early as the 1600s, it was identified that there were issues with continued tobacco use, specifically breathing issues, as well as the difficulty of quitting the use of tobacco was identified that early. In 1632, Massachusetts passed its first legislation that prohibited the public use of tobacco, specifically because of some of the issues that individuals were having. It was then rescinded, but this has been something that's been identified for an extended period of time. Tobacco itself is not necessarily the issue for why individuals have a difficult time ceasing their use of tobacco products. The nicotine in the tobacco products is what has been identified as the culprit. It has a rapid onset of action when smoked. It's estimated that within 10 to 15 seconds, we see activity already in the brain. Most of that activity is thought to be due to agonist activity at the nicotinic acetylcholine receptors, specifically calling out the subtype alpha-4 beta-2, recognizing there's quite a bit of affinity for this, as well as a relatively high prevalence of these receptors. Nicotine acting on the nicotinic acetylcholine receptors opens these ligand-chained receptors, and we see a depolarization of those neurons. This can result in a release of a number of different neurotransmitters. Dopamine tends to be the one that we focus on a little bit when we think of tobacco use disorder, because the dopaminergic activity has been associated with the pleasure response, some of the appetite suppression, and may make it, with that reward pathway, make it a little bit more difficult for patients to abstain from use. But dopamine's not the only neurotransmitter that gets activated. Increases in serotonin have been identified, epinephrine and norepinephrine, acetylcholine, GABA, vasopressin, glutamate, and beta endorphin. With all of those neurotransmitters, as individuals smoke, once they become tolerant to some of the effects of nicotine, we could see an improvement in mood, a reduction in anxiety. It can cause a little bit more alertness, where individuals feel like maybe their cognition is somewhat enhanced. It can raise blood pressure and heart rate for a small period of time. So if they do need that arousal, it may also suppress appetite across the board with a few different of the neurotransmitters, and it's been associated with analgesia as well as changes in memory. So there may be individuals who've been using this that actually state that they feel better when they use it. Unfortunately, for some of the patients, when we get to the use disorder piece, they're really just using more as a way to try to stave off some of the withdrawal symptoms that may occur. I wanted to focus a little bit closer on patients who have a diagnosis of a mental illness. So tobacco use in general has been identified as a major problem. 6 trillion cigarettes were produced in the late, around 2017, 2018. That was enough for more than 1,000 cigarettes per person, per man, woman, and child across the globe. So the fact that we're producing so many, it is being used in a lot of different populations, and patients who have a mental illness tend to be overrepresented in patients who are continuing to use tobacco products. So they're 2 to 3 times more prevalent for having use if they do have a psychiatric disorder. About 45% of all the cigarettes smoked in the US in 2015 were smoked by patients who did have a mental illness. And when they looked at populations, those that were in either mental health treatment settings or substance use disorder treatment settings, they found that the vast majority of patients were active smokers. Because of this, tobacco use is the cause of about 5 million deaths annually, and the complications range throughout the body. Cancer being one of the drivers, but it can cause cardiovascular disease, diabetes. We see impairments in erectile dysfunction, impaired fertility, potential adverse effects for the newborn, a weakened immune system, a range of lung diseases, as well as macular degeneration. There were quite a few others where there's been an association, but may rely on a couple other factors, but these were the ones that were listed specifically in the Surgeon General's report. So recognizing that there's these adverse consequences, how can we help these patients? What is it that we can do to help them with their tobacco use disorder? We have a range of approved treatments for tobacco use disorder. So nicotine replacement therapy, I am going to group these together. Bupropion as well as Varenicline are some of our agents that we have currently available. Recognizing that we have 3 different agents, they work in a somewhat similar way, although not exactly the same. So with our nicotine replacement products, we're looking at replacing the nicotine. So having another nicotine agonist to activate those nicotinic acetylcholine receptors, have some of those effects without some of the other carcinogens and chemicals that are found in tobacco products, and slowly be able to wean the patient down is what the goal is for most of these products. For bupropion, this is a dopamine norepinephrine reuptake inhibitor. While they don't know all of the actions, they believe that by enhancing the amount of dopamine and norepinephrine that are around, it can assist with some of the withdrawal symptoms, some of the cravings that patients may experience, and allow the patient to start to make some other behavioral and lifestyle changes to avoid the use of tobacco products. And then Varenicline is a partial agonist specifically at that alpha-4 beta-2 receptor. So being able to get some activity there, which may blunt the amount of activity that they would get if they were smoking a cigarette while they're on the Varenicline, but still not have nothing there. So they continue to get some of those effects. And then eventually the goal is to taper them off. So recognizing they work in slightly different ways, but we really are focused on the acetylcholine receptor as well as dopamine. What do we see? How can we use these? For the nicotine replacement products, we have a number of different formulations that can be used. Nicotine itself is not well absorbed. It's not very bioavailable orally, so we use a number of other types of formulations. The gum, where it's encouraged that patients not necessarily swallow all of it, so they can absorb quite a bit of it from the buccal cavity. The inhaler, the lozenge, again, trying to keep absorption within the oral cavity, nasal spray, and a patch. So a few different ways to try to get around those bioavailability issues. With the exception of the patch, the vast majority of these other formulations are encouraged to be used either on a scheduled basis and then with PRN supplemental dosing, or where they're taking the gum or the lozenge every few hours if they need it. Especially at first, it tends to be a little bit more successful if they have a schedule and then can supplement from there. In terms of adverse effects, we do see a handful of adverse effects. They tend to be more specific to the type of formulation the patient is using. Chest pain and heart palpitations have been identified, although in the meta-analysis that we'll talk about in just a few minutes, they pulled data from tens of thousands of patients that had exposure to nicotine replacement products, and the adverse effects of chest pain and heart palpitations were relatively rare. They did not see cardiovascular events such as myocardial infarctions or any type of a stroke occurring more frequently in patients on nicotine replacement products than on patients that were on placebo. So while this did happen, it occurred in less than 5% of the patients that were on nicotine replacement products. Although, to be fair, in those clinical trials, usually patients with existing cardiovascular conditions were excluded. So a consideration, but not necessarily a contraindication. More common adverse effects are hiccups, potentially nausea, especially with things like the gum and the lozenge, jaw pain from the gum, usually more from the gum than from the lozenge. Also can have some jaw pain or throat irritation from the inhaler, and potentially the nasal spray, especially if it drips down the throat. And then skin irritation predominantly from the patch. In some cases, it can cause some insomnia, potentially some irritability. So other things to watch for, but these are the ones that are reported most frequently. So do they work? We've got a whole bunch of them. Are they effective? This was the systematic review that I pulled. There's a ton of information. So this really is, I'm trying to give you a high level overview. This systematic review looked at interventions that use nicotine replacement products compared to placebo. So it was gum versus placebo, inhaler versus placebo, lozenge versus placebo. For all of these products, they were significantly more effective than the placebo product was, between 1.5 to 2 times more effective than placebo. And as you can see, there was a variable number of trials that were included in this review. The gum and the patch by far had the most number of trials that were included. The inhaler, the lozenge, and the nasal spray had a fewer number, but still continued to demonstrate the efficacy over placebo. Those were the data for short-term trials. Most of those trials were anywhere between 8 and 12 weeks. I believe some of them may have gone as far as 24 to 26 weeks. When they pooled all of the efficacy data from the clinical trials and looked more long-term at a follow-up that was 6 months or longer, they found that patients who had been on nicotine replacement products still were more likely to be abstinent and to have quit smoking tobacco products than patients who were randomized to the placebo groups. So that rate was 1.55. So it didn't matter which one they were on, even at that 6-month mark, they still were more likely to have quit. So these could be options, although they're not going to be a great fit for every single person. So looking at some of our other options, the next two are prescription only products. So our Bupropion, the recommended dosing for the tobacco cessation is 150 milligrams daily for the first 3 days, and then increasing to 150 milligrams twice daily. With that being said, there have been reports of patients starting at 75 or a lower dose for some patients, or maintaining at a lower dose, either 75 or 150 milligrams daily. For most of the clinical trials we're going to look at, this was the dosing regimen that they used. They did allow the flex down to 150 once daily, but they really preferred the twice daily. This product is recommended to be initiated a week prior to the quit date. So patients would be smoking in the first week that they are on the product, as opposed to the nicotine replacement products where they really recommend the one-to-one switch. They start the nicotine replacement therapy and they've quit smoking, and they're not doing both together. Adverse effect wise, we see a different adverse effect profile. These were adverse effects that were reported more than 10% of patients who were in the clinical trials. Dizziness, insomnia, nausea, and vomiting tended to be the most frequent. And there was a consideration for patients who had bipolar disorder, as well as those with an eating disorder or with a seizure disorder. As there is the potential with bupropion being an antidepressant, they didn't want to destabilize a patient's mood for bipolar disorder patients. And those with eating disorders or seizure disorders, it does lower the seizure threshold. So they were excluded from most of the trials. So does this one work? There was again, a systematic review that was done that pooled quite a few trials. Hold on just a second. So they included more than 44 trials with over 13,000 patients. They split the trials into short-term trials as well as trials that had long-term outcomes. When they looked at the short-term trials, there was a huge range in how effective bupropion was for being effective in having patients quit. The range for bupropion was anywhere between 4 and 43% of patients. So less than half the patients were successful in the short-term quitting. It was significantly more effective though than the placebo. And the rates for the placebo were anywhere between 0 and 33%. So only about a third of those patients were successful in the short term in quitting their tobacco use. When they looked farther out, more long-term data, there were a couple reviews that included 6-month data. So at the 6-month mark, were the patients still abstinent? In the one review, they included 5 studies, and they did not find a difference between placebo and bupropion in patients who were still abstinent. So that was considered to be somewhat unsuccessful, although there were more patients than they expected in the placebo group who had remained abstinent. All of those patients had been enrolled in counseling studies or in counseling programs in addition to the bupropion or placebo. So potentially it was a more motivated group to quit smoking or using their tobacco products. In the other review, which actually was a little bit older, and they did include somewhat similar trials, they did find a significant advantage for patients in the bupropion group in quitting their tobacco products compared to the placebo group. So it looks like long-term, there may be a little bit of inconsistency in how effective the bupropion itself is. In some of these cases, the bupropion was able to be continued. In other cases, it was discontinued at 12 or 24 weeks, and then the patients, or at 12 or 20 weeks, and then the patients were followed up at a 6-month time frame. For the 12-month abstinence data, they did have results from 27 different studies. Again, for these studies, not all of the patients continued on bupropion. They may have had their course and then just had a 12-month follow-up time frame. They did find the bupropion to be more effective than the placebo in patients who reported abstinence at that time. So a little bit inconsistent, but potentially an option for some other patients. The last agent we have is the Varenicline. So its recommended dosing is 0.5 milligrams for the first 3 days, 0.5 milligrams twice daily, and then increasing to 1 milligram twice daily. The duration a little bit flexible for as long as patients are going to take it. And in some cases, it has been extended out even longer than a year. In terms of adverse effects, nausea, insomnia, and abnormal dreams tend to be the most significant. They did limit the number of patients with mental illness in their initial clinical trials, which made it difficult to extrapolate to that population. So for this review, when I looked at the data, I wanted specifically to look at that population. So this was a review that looked at patients who had a diagnosis of mental illness. Most of them had schizophrenia, schizoaffective disorder, or bipolar disorder, who were randomized to either Varenicline or placebo in an attempt to stop using tobacco products. Across the board, short term, they did find that Varenicline was significantly more effective than placebo. There was one group that had a relatively large confidence interval that wasn't found to be statistically significant, but the remaining 3 trials were significantly more effective than the placebo group. When they looked at long-term abstinence, they also found that Varenicline patients treated with Varenicline were significantly more likely to continue to be abstinent than those patients in the placebo group, even if they dropped the dose. So in the Cahill review, they split their Varenicline data and they looked at patients who continued on Varenicline and had used the 1 milligram twice daily. And then they looked at patients who had to reduce their dose and whether it was short term, like 12 to 20 weeks of treatment, or if they had extended. And they found that even the lower dose, 0.5 milligrams once daily or 0.5 milligrams twice daily, they were more likely than placebo to be abstinent at that follow-up time frame 6 months later. So Varenicline did look to be an advantage, and in most of the literature that's available, this is identified really as the most effective pharmacologic treatment that we have. But that's not the end of the story. We like to stay with one, but the question really is more better. So there are some combination trials that are available. I focused on the pharmacologic treatment. The non-pharmacologic treatment and therapy really does need to be included as well, but this is just looking at combination drug therapy. When they looked at Varenicline and nicotine replacement therapy, there was a review that was done that included 3 trials, over 900 patients, and they found significant improvement in their abstinence rates. So the blue bars in the first 2 categories here are patients on Varenicline and nicotine replacement therapy. The red bars are the Varenicline alone group. The first set are abstinence short-term, so 12 weeks or less. And the second group is abstinence later, so longer than 12 weeks is how they captured it. And they found that significantly more patients in the combination group were able to maintain abstinence at their endpoint, whether it be 12 weeks or a later time frame than those that were just on Varenicline monotherapy. Same results for the Varenicline Bupropion group. This was a review that included 4 trials and over 1,000 patients. The green, so again, the red is just Varenicline. The green is the Varenicline and Bupropion. They actually found in their longer term trial, which included a couple, at least one study that was longer than a year, they had over half of those patients continue to be abstinent at that endpoint. So again, it seemed to be significantly more effective than just the Varenicline alone. So for some patients, it may be beneficial to look at combination therapy. Now, the last thing I just wanted to cover, because this popped up in quite a few different places, especially with the more recent literature looking at, there's quite a bit out there on treatment for tobacco use disorder, but in the more recent trials, this did come up quite a few times. So the role for electronic cigarettes. It has been identified as a potential intervention for patients with tobacco use disorder that are trying to quit cigarette smoking. I was able to find a systematic review. So it included 50 trials with over 12,000 patients. For full disclosure, 24 of those trials were non-randomized. So they may have been retrospective or naturalistic studies. The intervention groups that were included were primarily electronic cigarettes versus nicotine replacement therapy. So not necessarily looking at it compared to Bupropion or Varenicline. They did find that the quit rates, in quit, I put in my own, I'm drawing attention to it because quit means that they're not smoking cigarettes. They're tobacco cigarettes, but it doesn't necessarily mean that they're not using the electronic cigarettes. They could still have been using those and considered to have quit if they didn't go back to what they had been using previously. They reported that there was significant improvement in patients randomized or in using electronic cigarettes than those that were using the nicotine replacement therapy. And they estimated that the number needed to treat to improve quit rates, that you could improve 2 to 4 patients per 100 if they were using electronic cigarettes over nicotine replacement therapy. And the range they gave was between 2 and 8 patients. So there is a push from a couple different places to consider this a treatment option. Adverse effect profile-wise, there was no difference between nicotine replacement therapy and electronic cigarettes, although long-term safety data with the e-cigarettes and other vaping oil has not been identified. So it may be possible that even with those electronic cigarettes, they're getting higher concentrations of nicotine than we could ever deliver with the nicotine replacement products, and that they could ever get with the traditional cigarettes. So just a narrative that's out there that I wanted to make sure that we addressed. So I will wrap up here. There are quite a few different options we can use. Monotherapy, Varenicline seems to be superior, but we do have some evidence that combination therapy of Varenicline with nicotine replacement products and with bupropion tends to be better, although there are some other suggested interventions to help patients be successful in quitting their tobacco use.